Welcome to the deep dive. Today we're really getting into some foundational science, specifically Chapter 29 from Porth's Essentials, Structure and Function of the Respiratory System. It's absolutely critical stuff.
Absolutely. Our goal here is to take this, quite dense pathophysiology material and make it really clear, really accessible. We're going beyond just O2 and CO2. We're looking at the whole picture, the elegant structure, the mechanics, gas transport, and how the nervous system keeps it all ticking.
And let's tackle a common idea right away. People often think of lungs as just, passive bags for air, but the source material really stresses three main jobs. Gas exchange, yes, obviously number one.
But just as vital are the host defense functions acting as a barrier and something often overlooked. It's metabolic activity.
Ah, the metabolic part. That's often a surprise, isn't it?
It really is. The lungs are like a little chemical processing plant. They make and break down various compounds. And crucially, they have the enzyme ACE that converts angiotensin I into angiotensin II.
Angiotensin II, the powerful vasoconstrictor.
Exactly. So the lungs are directly plugged into regulating your systemic blood pressure. It's way more than just breathing. It's a metabolically very active organ.
Okay, so let's unpack the structure, the blueprint. How does the air actually get to where it needs to go? The chapter splits it into two zones, right?
That's right. You've got the conducting airways, think of them as the pipes, and then the respiratory airways, which is where the actual gas exchange happens.
So the conducting part, nose, trachea, bronchi.
Yeah.
What's their main job, if not gas exchange?
They're all about conditioning the air, warming it up, filtering out particles, adding moisture. They just move the air down towards the lungs. No gas crosses over here.
Filtering. So how does that work? How does it trap stuff?
That's where the mucociliary blanket comes in. It's this sticky layer of mucus that traps dust, pollen, bacteria, whatever you breathe in. And then these tiny little hairs, the cilia, are constantly beating upwards.
Like a little escalator.
Exactly. Moving that trapped gunk up towards your throat so you can swallow it or cough it out. It's a continuous cleaning system. And the text makes a really key point about smoking here.
Right, it damages the cilia.
Yeah, it slows them down, can even paralyze them, which means the cleaning system gets seriously compromised. Big implications for infections and irritation.
Okay, so air gets cleaned and conditioned, then moves into the respiratory zone, the alveolar ducts, and finally the alveoli themselves.
The alveoli, these are the tiny air sacs, the main event for gas exchange. We're talking about something like 300 million of them in an adult.
And the surface area is huge, isn't it?
Massive. Around 50 to 100 square meters, think like half a tennis court, maybe more, all packed into your chest.
Wow. And these sacs are lined by special cells, pneumocytes.
Two main types. Type I alveolar cells make up about 95% of the surface. They're incredibly thin, like wafer-thin squamous cells. That thinness is key for easy gas diffusion.
But there's a catch with type I cells.
Yes, a critical one. They cannot divide. If they get badly damaged, that part of the gas exchange surface is just gone. You can't regenerate it easily.
Okay, so that makes the type 2 alveolar cells pretty important then.
Hugely important. They're more cuboidal, and they do two vital things. First, they're the backup the progenitor cells. They can divide and then change into type I cells to repair damage.
Okay, repair crew. What's the second job?
They produce pulmonary surfactant. This stuff is absolutely essential.
Surfactant. I know it reduces surface tension, but how exactly does it work?
Right. It's a mix of lipids and proteins. Specific proteins, SPB and SPC, are the ones that really insert themselves into the water layer, lining the alveoli, and disrupt the surface tension. This makes the lungs easier to inflate, increases compliance, and prevents them from collapsing, especially the smaller alveoli.
And you mentioned other surfactant proteins, SPA and SPD.
Yeah, they have a different role, more related to innate immunity. They act like tags, opsonins, helping the immune cells identify and grab onto bacteria or other pathogens.
Speaking of immune cells, what about macrophages down there?
Ah, yes, the alveolar macrophages. They're the cleanup crew inside the alveoli. They basically wander around engulfing any dust or particles that made it past the mucociliary blanket. And they play a key role in infections like TB.
Tuberculosis, right. They form those granulomas.
Exactly. They engulf the M. tuberculosis bacteria, but often can't kill it. So they, along with other immune cells, wall it off inside a fibrous capsule. That's the tubercle. It's a way of containing the infection.
Okay, so we have the structure, the cells. How does it all get blood and nerve supply?
It's got a dual circulation, which is interesting. First, the pulmonary circulation. This comes from the pulmonary artery, carrying deoxygenated blood from the right heart. It's a low-pressure, high-flow system designed purely for gas exchange.
Low pressure, high compliance. Makes sense for handling the entire heart's output without too much resistance.
Precisely. But then you also have the bronchial circulation. This branches off the aorta, carrying oxygenated systemic blood. Its job is to feed the tissues of the conducting airways themselves. The bronchi, the trachea, and other supporting structures, they need oxygen too.
And there's a little quirk where some of that bronchial blood returns.
Yeah, this is a neat detail. Some of the deoxygenated blood from the bronchial circulation drains into the pulmonary veins, which are carrying freshly oxygenated blood back to the left heart. So it creates a very slight dilution, a tiny bit of venous admixture.
Interesting. What about nerves? How is breathing controlled locally?
It's mainly the autonomic nervous system.
Mm.
Parasympathetic input, mostly via the vagus nerve, tends to cause a bit of baseline smooth muscle constriction and increases mucus secretion.
And sympathetic.
Sympathetic stimulation does the opposite. It relaxes the airway smooth muscle, causing bronchodilation, useful during exercise, for example.
Mm.
And a key clinical point, the lungs themselves don't really have pain fibers. The pain associated with breathing usually comes from the pleura.
Ugh, the pleura. The lining around the lungs. Tell us about that.
It's a double-layered membrane. The visceral pleura sticks right to the lung surface, and the parietal pleura lines the chest wall. Between them is the pleural cavity, containing just a thin film of fluid.
And this space is crucial for keeping the lungs inflated, right? The negative pressure.
Absolutely crucial. Think of two wet microscope slides. They slide easily, but resist being pulled apart. The pleural fluid does that. The lungs naturally want to recoil inwards due to elastic tissue, while the chest wall wants to spring outwards.
This creates a pull.
Creates a negative pressure in that pleural space, usually around -4 millimeters of mercury relative to atmospheric pressure when you're resting between breaths. This intrapleural pressure effectively sucks the lung surface against the chest wall, preventing the lung from collapsing.
Got it. Okay, let's shift to the mechanics, how we actually move air. It all comes down to pressure differences, doesn't it?
Entirely. And we measure everything relative to atmospheric pressure, which we just call zero for simplicity.
So what are the key pressures we need to know?
Three main ones. First, intrapulmonary or alveolar pressure. That's the pressure right inside the alveoli. Between breaths, when air isn't moving, it's zero, same as atmospheric.
Second, the one we just talked about.
Intrapleural pressure. Pressure in the pleural cavity, always negative in a healthy inflated lung, around -4 millimeters at rest.
And the third.
Transpulmonary pressure. This is the difference between the alveolar pressure and the intrapleural pressure. It represents the pressure distending the alveoli, keeping them open. It's a really important measure related to lung compliance.
Okay. So how do we change these pressures to breathe?
Muscles.
Right. Inspiration breathing in is active. The main player is the diaphragm. It's this big dome-shaped muscle at the base of the chest. When it contracts, it flattens and pulls down.
Increasing the chest volume vertically.
Exactly. And the external intercostal muscles between the ribs pull the ribs up and out, increasing the volume front to back and side to side. This expansion drops the intrapleural and then the alveolar pressure below zero, and air flows in.
And breathing out. At rest, it's mostly passive. The diaphragm and intercostals relax, and the natural elastic recoil of the lungs and chest wall just causes everything to shrink back down. This pushes alveolar pressure above zero, and air flows out.
But you can force air out, right?
Oh, yeah. If you need to exhale forcefully or quickly, you use your abdominal muscles to push the diaphragm up and your internal intercostal muscles to pull the ribs down and in. That's active expiration.
This brings us to compliance. How stretchy the lungs are.
Yep. Compliance is basically the ease with which the lungs can be inflated. Technically, it's the change in volume for a given change in pressure. C. High compliance means easy inflation. Low compliance means stiff lungs.
What determines compliance?
A few things. The elastic properties, the balance between stretchy elastin fibers and stiffer collagen fibers. Water content in the lung tissue can make them stiffer. And crucially, surface tension within the alveoli.
Surface tension again. This is where surfactant links back to mechanics.
Exactly. And it relates to a bit of physics, the law of Laplace. For a sphere, like an alveolus, the pressure needed to keep it open, P, is related to the surface tension, T, and the radius R, by P equals 2TR.
So smaller radius means higher pressure needed to stay open.
Correct. If surface tension were constant, smaller alveoli would require much higher pressure to stay inflated and would tend to collapse and empty into larger ones. It would be unstable.
But surfactant prevents that.
Yes, because surfactant molecules get more concentrated, packed tighter together in smaller alveoli. This drastically reduces the surface tension specifically in those small alveoli, equalizing the pressure across alveoli of different sizes and keeping everything stable. It's quite brilliant.
Okay, measuring lung function. PFTs, pulmonary function tests. What are the basic volumes?
We start with static volumes. Tidal volume, VT, the amount you breathe in and out normally. Then you have reserves. Inspiratory reserve volume, IRV, is how much more you could breathe in after a normal breath. Expiratory reserve volume, ERV, is how much more you could force out after a normal exhale.
And there's always some air left.
Always. That's the residual volume, RV. About 1,200 millio you can never fully exhale. It keeps the alveoli from completely collapsing.
And combining these gives capacities.
Right. Vital capacity of VC is the total amount you can move. IRV plus VT plus ERV. Functional residual capacity, FRC, is what's left after a normal exhale. ERV plus RV. FRC is important. It's the air buffer where gas exchange continues between breaths. Total lung capacity, TLC, is everything. VC plus RV.
Clinically, though, the dynamic tests are often more revealing.
Very much so. We look at forced vital capacity, FVC, breathe in fully, then blast it all out as fast as possible. And within that, we measure the forced expiratory volume in 1 second, FEV 1.0.
Why that first second?
Because the ratio, FEV 1.0 divided by FVC, tells you about airflow obstruction. In healthy lungs, you can get most of the air out in that first second, so the ratio is high, maybe 75–80%. But in obstructive diseases like COPD or asthma, airway resistance is high, slowing airflow, so the FEV 1.0 drops significantly, and that ratio goes way down. It's a key diagnostic marker.
Makes sense. And patients adjust how they breathe based on their lung issues. The work of breathing.
They do, unconsciously, to minimize effort. If lungs are stiff, low compliance, it's easier to take small, rapid breaths, less work stretching stiff tissue. If airways are obstructed, it's easier to take slow, deep breaths to minimize the frictional resistance from fast airflow.
Okay, let's move to the main event. Gas exchange. It needs 3 things aligned.
Yes. Ventilation V, getting air to the alveoli. Perfusion Q, getting blood to the alveolar capillaries. And diffusion, the actual movement of gases across the membrane. They all need to be matched the VQ ratio.
And when they're not matched, we get VQ mismatch. 2 main types.
2 main ways it goes wrong. First is dead space. This is ventilation without perfusion, high VQ. Air reaches alveoli, but there's no blood flow to pick up oxygen or drop off CO2.
Like a pulmonary embolism blocking a vessel.
Classic example. We distinguish anatomic dead space, the air just sitting in the conducting airways that never participates in exchange from alveolar dead space, which is this ventilated but unperfused alveoli situation.
And the opposite problem
is shunt. Perfusion without ventilation. Low VQ. Blood flows past alveoli that aren't getting fresh air, maybe because they're collapsed atelectasis or filled with fluid pneumonia.
So that blood doesn't get oxygenated but still returns to the left heart.
Exactly. It's shunted past the lungs without participating in gas exchange, mixing deoxygenated blood with oxygenated blood.
Is there any way the lungs try to compensate for mismatch?
Yes, a really unique mechanism. Hypoxia-induced vasoconstriction. Unlike blood vessels elsewhere in the body that dilate in response to low oxygen, the small pulmonary arteries constrict when alveolar oxygen is low.
Why would they do that?
It's smart, locally. It automatically diverts blood flow away from poorly ventilated areas and sends it towards areas that are getting oxygen. It helps optimize VQ matching on a regional level.
But what if the whole lung is hypoxic?
That's the danger. Widespread hypoxia causes widespread vasoconstriction. This increases resistance in the pulmonary circulation, leading to pulmonary hypertension. Chronic pulmonary hypertension puts a huge strain on the right side of the heart, potentially causing right heart failure, which we call cor pulmonale.
Okay, assuming V and Q are matched, let's talk diffusion. What affects how fast gases move across that thin alveolar capillary membrane?
Several factors. Surface area, more area, faster diffusion. Membrane thickness, thinner, is faster. The partial pressure gradient, bigger difference, drives faster movement. And the gas characteristics.
And CO2 diffuses much faster than O2.
About 20 times faster. Not because its gradient is bigger, but because it's much, much more soluble in the membrane lipids and water than oxygen is. It just dissolves across more easily.
Right, now oxygen transport, how does it travel in the blood?
The vast majority, 98 to 99%, binds to hemoglobin inside red blood cells. Only a tiny fraction, 1 to 2%, is dissolved directly in the plasma. But it's this dissolved portion, measured as the partial pressure of oxygen, PO2, that actually creates the gradient to drive oxygen into the tissues.
And the relationship between PO2 and how much O2 is bound to hemoglobin isn't linear, is it? The famous curve.
The oxygen-hemoglobin dissociation curve. Yeah. It's S-shaped. It's pretty flat at the top in the high PO2 range found in the lungs. This means hemoglobin gets almost fully saturated even if alveolar PO2 drops a bit. good safety margin for loading.
But the steep part is at the tissue level.
Exactly. In the lower PO2 range found in metabolically active tissues, the curve is steep. This means even a small drop in PO2 causes hemoglobin to release a large amount of oxygen. Very efficient unloading where it's needed.
And this curve can shift. This is clinically super important.
Absolutely critical. A shift to the right means hemoglobin has less affinity for oxygen. It lets go of O2 more easily at any given PO2.
When would that happen?
When tissues are working hard, increased CO2, PCO2, increased acid, lower pH, increased temperature, fever, and increased levels of a substance called 2-choro-DPG in red blood cells. All signals of high metabolic activity push the curve right, promoting oxygen release.
Makes sense. Facilitates delivery. And a shift left.
Shift to the left means increased affinity. Hemoglobin holds on to oxygen more tightly. This happens with decreased PCO2, decreased acid, higher falcalosis, decreased temperature, less metabolic demand so O2 isn't released as readily. We often use the PO2 needed for 50% saturation to quantify the shift.
Okay. Quickly, how about CO2 transport back to the lungs?
3 ways. About 10% is just dissolved in plasma. Around 30% binds directly to hemoglobin at a different site than O2, forming carbaminohemoglobin.
And the majority?
The majority, about 60%, is converted into bicarbonate ions, HgO3. This happens fast inside red blood cells thanks to the enzyme carbonic anhydrase.
Carbonic anhydrase speeds up CO2 plus water, carbonic acid.
Massively speeds it up. The carbonic acid then quickly splits into bicarbonate and a hydrogen ion, H+. The H+ gets buffered by hemoglobin, and the bicarbonate moves out into the plasma.
But that would change the electrical charge.
Right, so to maintain electrical neutrality, as bicarbonate leaves the red cell, a chloride ion, Cl, moves in. That's the bicarbonate chloride shift, or hamburger shift. It allows huge amounts of CO2 to be carried as bicarbonate in the plasma back to the lungs.
Incredible system. Okay, last big piece. Control. How does the brain tell us to breathe?
The main control center is in the brainstem, specifically the pons and medulla. It contains groups of neurons that act like a pacemaker, generating the basic rhythm. You have dorsal groups, mainly for inspiration, ventral groups for both inspiration and expiration, especially forced breathing.
And centers in the pons fine-tune it.
Yes, the pneumataxic center tends to switch off inspiration, helping control rate and depth. The apneuristic center seems to prolong inspiration, though its exact role is a bit less clear. But the real moment-to-moment regulation comes from chemical feedback.
Chemoreceptors. Central and peripheral.
Exactly. The central chemoreceptors are located right there in the medulla. They are incredibly sensitive to changes in the pH of the cerebrospinal fluid, CSF.
And CSF pH is mainly driven by CO2.
Yes, because CO2 diffuses easily from blood into the CSF, forms carbonic acid, and releases H+ Clopax. So these central receptors are effectively monitoring blood PCO2. A tiny rise in PCO2 causes a strong, immediate increase in ventilation to blow it off. They're the main drivers for normal breathing regulation.
But they can get worn out. You mentioned CO2 narcosis earlier?
Right. If PCO2 stays chronically high, like in severe COPD, these central chemoreceptors can become desensitized, less responsive. They sort of give up trying to correct the high CO2.
So then what drives breathing?
The backup system kicks in. The peripheral chemoreceptors. These are located in the carotid bodies, at the bifurcation of the common carotid arteries, and the aortic bodies, in the aortic arch.
What do they sense?
They can sense PCO2 and pH, but their primary stimulus is low oxygen, a drop in blood PO2. However, they don't really fire significantly until the PO2 drops quite low, typically below 60 millimeter Hg.
So this is the hypoxic drive.
That's exactly it. In those patients with chronic high CO2 whose central receptors are blunted, their main stimulus to breathe becomes this low PO2 detected by the peripheral chemoreceptors.
And that's why giving them too much oxygen can be dangerous.
Precisely. If you give high-flow oxygen and raise their PO2 above that 60 millimilli Hg threshold, you remove their primary remaining stimulus to breathe. Ventilation can decrease dramatically, even leading to respiratory arrest. It's a critical clinical point based directly on this physiology.
We also have protective reflexes, like coughing.
Yes, the cough reflex is neurally mediated. Starts with irritation, then a deep breath in, the glottis closes, expiratory muscles contract, forcefully building up pressure, then the glottis flies open, causing that explosive expulsion of air to clear the airways.
And finally, dyspnea, the feeling of breathlessness.
Dyspnea is subjective, the sensation of difficult or uncomfortable breathing. The chapter notes it occurs mainly in 3 situations: primary lung diseases, like COPD, asthma, pneumonia, heart disease leading to pulmonary congestion, and neuromuscular disorders affecting the breathing muscles.
Okay, let's recap the big takeaways. First, structure dictates function. conducting airways condition air, respiratory airways exchange gas. Second, mechanics are all about pressure gradients, compliance, and the vital role of surfactant, explained by Laplace's law.
Third, efficiency hinges on matching ventilation and perfusion, VQ, and the dynamic nature of oxygen transport via the O2 hemoglobin curve, which shifts based on metabolic needs.
And that brings us to our final provocative thought, thinking about that neural control. The fact that someone with severe chronic lung disease shifts from relying on the sensitive CO2 drive to the less sensitive low O2 drive.
It fundamentally changes clinical management, doesn't it? It dictates how carefully you have to administer oxygen therapy. That shift from CO2 sensitivity to hypoxic drive isn't just textbook physiology, it's a life-or-death consideration at the bedside. Understanding that mechanism is paramount.
Absolutely. It really highlights how understanding the fundamentals informs practice. Thank you for joining us on this deep dive into respiratory structure and function. We hope this breakdown helps solidify these core concepts for you.